Good evening, everybody. I'm Dr. 𝗬𝗏𝗃𝗀, the medical advocate, and I'm so happy that you're here with me tonight. You might remember that 2 weeks ago, we discussed how to work up a cardiac patient or a patient with a potential heart problem. We went through various aspects of it. We went through stress testing, advanced cardiac test, laboratory testing, coronary calcium scan, and also a new test called the pulse test. But tonight we're going to focus on the second aspect, which is laboratory testing. And it's probably the most important one because that's when we go to time after time after time when it comes to working with your risk factors, your individual risk. Because you might remember one thing about me, I don't care how low your LDL cholesterol is, but I do care about what your individual risk is. And by using the appropriate laboratory testing, we can find that information and we can test it over a period of time. Now, your average lipid panel that your average doctor, even cardiologist, orders really is basically four things: total cholesterol, LDL, or what I call lousy cholesterol, HDL, which we know as healthy cholesterol, and triglycerides. That's really not the complete picture, and it's a very simplistic way to screen people for lipid disorders. But you need to know that the LDL is actually not really measured, it's calculated. And if the triglyceride level is greater than 400, you really can't calculate it. So it really is inadequate, but it's a decent screen. So as medical advocates, we go beyond that and we do what's called advanced cardiac testing or lipid testing. So we're going to go through a few things in the alphabet soup. So Apob, small dense LDL, HDL2B, CRP, trig for triglycerides. There's a whole plethora of symbols that we use, and I'm going to try to make them pretty easy. First of all, you need to know that cholesterol doesn't just travel in the blood by itself. It's not just transported freely, it's connected to a protein molecule. So LDL is produced in the liver and also in the gut. And actually it's transported throughout the body to various places, one of which is the arteries. And as long as those arteries are intact, there's not a problem. And when there's inflammation, the LDL is attracted there and the LDL is oxidized, then we have the formation of plaque. And that begins the whole process. But LDL is also very essential for the brain because LDL cholesterol is important for myelin sheath, which protect the individual neurons, and also it helps to build new neurons. So I don't know about you, but I don't want a good heart with a bad brain. So LDL is not something to be vilified. It actually has some important aspects to it. But let's delve further into this alphabet soup that I call it. One is called the LDLP, or the LDL particle number. Now, the LDL itself is basically a measure of the amount of LDL cholesterol in a particle. But the LDL particle number is a much broader number, and it actually tells you the number of particles in a particular sample. So why do I even care about this? Because you can have a normal LDL and an elevated LDL particle number. And it's felt that the LDL particle number may be a stronger predictor of cardiac risk. So here's a simple way of of actually figuring out what's really important. Let's say your LDL is 80. Okay, if you add a 0 onto that, that should give you where your LDL particle number should be. It would be 800. But let's say the LDL is 80 and your LDL particle number is 800. It's more like 1200. And that's an elevated LDLP, and that's of concern because, again, the larger the particle number, the more risk the patient is for future cardiac events. There's also something we call Apob, which you actually look at the protein particle, the protein portion of the LDL particle. And Apob is very similar to LDL particle number. It's talking about the amount of LDL in a sample. And again, it portends it's a better prognosticator of coronary disease. But what I really care about is the LDL size. And I've alluded to that in the past. So bigger is always better, at least when it comes to LDL for sure. Because the smaller it's two basic sizes: large buoyant or large fluffy, and small dense. The large buoyant is the better pattern to have. It's less likely to get oxidized and become incorporated into the artery wall as plaque. However, small dense LDL is more likely to get oxidized, which is a chemical process, and it makes it much more easy for these particles to actually delve into the arterial wall and cause plaque. So if you have small dense LDL, it's about a threefold increase in cardiac risk as opposed to large fluffy. So it does make a difference. Size does make a difference. And again, you would not know this unless you did advanced cardiac testing. So with advanced cardiac testing, we're going to know the LDL particle number and we're going to know the LDL size. Now, what about HDL? HDL is a healthy cholesterol that we've always talked about. And we used to think that bigger is better for that too. It is to a certain extent. If you have an HDL upwards of 80 or so, it's probably a good prognostic sign because this is what we call reverse cholesterol transport. HDL actually takes cholesterol from the circulation, brings it back to the liver for disposal. So we've always thought of it as something good. But then again, there's always been something kind of questionable HDL because there's been various trials in the last 25 years or so, which we actually came up with pharmaceuticals that could increase the HDL. However, by doing that, all the trials, or at least 3 which come to my mind, were halted because there was actually a higher incidence of death and or cardiac events. So it's something different about HDL. Is bigger really better? Now we're looking at things called the HDL functionality, which seems to be really promising. I personally think that there's promise in HDL, that it's a good thing, as long as we have the appropriate testing. So this functionality has not been standardized yet at all. So it's looking really good research-wise, and I hope in the next 2 or 3 years we'll have some good testing for HDL functionality, which I think will be a better prognosticator side, on a positive sense, than the size of the HDL particle. HDL2B is kind of being phased out. That was the large HDL particle, and we thought that bigger was better for that. But actually, patients that have levels of 90, 100, and over 100. And we used to think that was really good, but it's now probably thought not to be good and could actually possibly be bad. So stay tuned for more information about HDL functionality. Lp(a) is another one. Now Lp(a) is a fragment of LDL. It's genetic. It's usually runs in families. And I think one reason why doctors don't order it, because there's no pharmaceuticals out there that can treat it. But make no mistake about it, it is not a good thing to have. It tends to be very sticky, very inflammatory particle, and it clearly increases your risk of coronary disease. I do Lp(a)s on all my patients, especially if they're young, because I'm looking for that inherited kind of trait. Now, again, like I said, it's not real popular because there's no medicines to treat it. Now, I do use niacin, which is actually a vitamin B3. However, when we use it in large doses, it becomes more like a drug than an actual vitamin. And niacin can decrease the Lp(a) by as much as 25 to 40%. So I've had some good luck with it. It doesn't work in everyone, but I've had people be able to decrease their Lp(a) numbers significantly with niacin. There have been other studies with alcohol, like most specifically red wine, fish oil. They may have some additive effects, and estrogen in women. Some other exciting things happening. You may have heard about these new agents out there called Pcsk9 inhibitors. They're biologics, and they're injected subcutaneously twice a month. And they're very good at lowering LDL cholesterol, but they also might have a definite role in lowering Lp(a). So it's not indicated of that yet, and there are trials underway right now as we speak. So we'll be hearing more about that. Also, there's another biologic that's being studied right now, I believe in UC San Diego, and that has real promise. And I think in a matter of 6 weeks, it can decrease Lp(a) by as much as like 50, 60%. So it's really exciting. And I think that will make a major difference when it comes to treating coronary disease. TRIGs is an abbreviation for triglycerides. Now, triglycerides have never really been shown to be an independent risk factor for heart disease. However, make no mistake about it, it's not a good thing to have. Usually, it connotes poor metabolic health. And we've talked about metabolic health before on YouTube Live. And you may remember a study I cited about maybe a month or 6 weeks ago, that only 12% of the adult American population is metabolically healthy, which means 88% is not. It's a big deal. So what are the things we look for if the triglyceride level is high, if the HDL level is low, and if they have small dense LDL, that's definitely going to be someone who's metabolically unhealthy. So we measure trigs, and trigs are easily treated with diet. So we do use things like niacin. We use fibrates, a different kind of pharmaceutical, but you can do a lot with diet. And basically, it's not restricting fat, it's restricting carbohydrates. Because what happens, everything that you eat basically first goes to the liver for processing, and the liver gets overwhelmed with a lot of carbs. So what it does, it converts what it can to fat in the liver, which isn't a good thing, and dumps the rest in the circulation as triglycerides. So that's why we see the association of this entity called non-alcoholic fatty liver disease in people with high triglycerides. Okay, there's a couple other things I want to just briefly mention, and CRP. Actually, now there's Hscrp, which stands for highly sensitive C-reactive protein. And everybody should have this done at every lab test as far as I'm concerned. I mean, everyone gets this test. Why? Because it's a very sensitive, non-specific marker for inflammation. So inflammation is the bane of our existence when it comes to aging. I don't care if it's heart disease, cancer, autoimmune disorders, or Alzheimer's, they all have one thing in common, and that is inflammation. So I'm very big on that, and I work it up to see where could the possible focus be. Is it because of oral health or gut health or sleep apnea? Or is it actually an infection? Your CRP is normally going to be elevated when you have an active infection, and thank goodness, because that's our protection. But there are people walking around with CRPs that are elevated 365 days of the year, and that's not a good thing. That means they're chronically inflamed. If you look at the obese population, they're always going to have a high C-reactive protein, because although belly fat was thought to be inert, it's not. It's metabolically very active in a very negative way. So a lot of your cytokines that really become that explode during inflammation is in the belly fat. And there's a couple other things I want to just briefly mention. These are markers for unstable plaque. So LPPLA2. LPPLA2. I can spell it much better than I can pronounce it, because it really stands for lipoprotein associated phospholipase A2. I never can remember that. So this is actually, it's increased if you have inflammation within the artery wall itself. So it's more sensitive than CRP. It says, wow, it could be inflammation in the arterial wall, which is a bad sign. So we're always looking for ways to how to identify plaque that's active. That's one of them. And the other one is called MPO, myeloperoxidase, which is another enzyme. This is actually released by neutrophils, which is a white blood cell. That also becomes released during periods of inflammation. Is also associated with vascular inflammation, which portends plaque, unstable plaque, and the coronary artery process. So there's your bits of abbreviations, alphabet soup, as I like to call it. So now I'm going to look at some of these questions that you have. That's basically what I have. Okay. This is a person who said, I have inherited bad genes from my parents and warranted a statin from a traditional doctor. Okay, this happens all the time. I get patients that come in all the time that have seen other doctors, and the doctors wanted to place them on a statin. And they used to come to me for a second opinion. So what I will do is often do this battery of tests, and I use Boston Heart Diagnostics, which is out of Framingham, Massachusetts, or Cleveland Heart Lab, which is out of Cleveland. And Cleveland was bought by Quest Labs about 3 years ago, which makes it very easy, because if you go to a Quest lab, they will draw your Cleveland blood and send it to Cleveland for processing. Those are the two labs that I prefer, and it gives me a lot of really good information. So you have bad genes. Okay. All right. The genetic factors probably constitute about 20% of your risk when it comes to heart disease or really cancer or any disorder. But 80% is still related to lifestyle. So what I work on, of course, is I try to accentuate the lifestyle through diet and exercise and appropriate supplementation. And if I have to use pharmaceuticals, I will, because I want to do everything in my power to minimize your risk, not just lower your LDL. So again, so the person that asked this question should definitely have either Boston Heart or Cleveland, because we have to look at all the risk factors before we decide to just nilly-willy put you on a statin. So very common question. Okay, and here's my advanced cardiac test shows about 30% improvement on all numbers after 9 months of supplementation and lifestyle change, but still not great. So that leaves you with a dilemma. Okay, so if you've had 30% improvement after 9 months, that's pretty darn good. Maybe not perfect. So in that case, this is a young person. Couple things I would want to do. Then I would probably want to do a coronary calcium scan, which we talked about in the last session, and to actually see whether or not there's calcifications in the coronary artery. And it doesn't tell me what's happened in an active sense, but if the level is over 400, you can bet that it's a prognostically poor sign, and then I'd be really concerned. Then I might want to put you on a statin. Another thing I would look, another test is the pulse test, PULS, which I talked about in the last session as well, and that is a biochemical test. And it tells me how your body is reacting to the plaque that may be there. And it gives me what's called a pulse score. And it's a new test, and I really like pairing that with this advanced cardiac testing, because I want to get as much information I can. But depending on the coronary calcium scan and the pulse testing, I may want to put you on a statin, but it would not be my first bet. Great questions. Okay. So what to do? I hope I answered that question. Another one, the red yeast rice supplement you would advise for me has made a huge difference. Great. Okay, so I used a lot of red yeast rice supplement. So for those of you who don't know, the first statin that came out in the 80s, the early to mid 80s, was 𝗻𝗄𝗃, and that was derived from the red yeast rice plant from China. Now, of course, a lot of medications, pharmaceuticals, are originally derived from botanicals, and then, of course, they're made in the laboratory, and fillers are put in there, and they're made more potent, and so forth and so on. So things do change, but that is how the first statin came about. So red yeast rice supplement, it's a tongue twister, actually is it's statin-like. It has statin-like properties, but it's weaker, and you don't get the same side effects. And I do use a lot of it. If someone really needs a statin, for high-risk patients, I will go to a statin, but if they're not really high risk, I will always usually try with supplementation first, and I happen to like red yeast rice supplement, and this particular person is a good friend of mine, and I'm so happy that we were able to get her numbers down, because her doctor was going to put her on statin. There was no question about it. They were determined to put her on statin, and she came to me first, so I'm glad. Okay. So I would definitely have to. Okay. Let me see. Can triglycerides be genetic, and can berberine help? Good question. Yes. Well, I think triglycerides really, cholesterol is definitely genetic, especially if you have Lp(a), if you have small dense pattern. Those are unfavorable patterns to have, and they tend to be inherited. Triglycerides is really metabolic. It's really diet and lifestyle. Again, these people tend to eat a lot of bad fats, processed foods, and a lot of carbs, and also a lot of alcohol. So all these things can increase your triglycerides. To me, triglycerides is the easiest thing to lower with diet if you're really committed to doing it. So is it genetic? Probably is, but I see so much of it. It's associated with diabetes, prediabetes, metabolic syndrome, non-alcoholic fatty liver disease, PCOS, polycystic ovarian syndrome. So even though it's not a direct risk factor for heart disease or one of the primary risk factors, it's clearly not a good thing to have. And I really work on that. That's a good question, though. What tests can be done to indicate inflammation? Are there different kinds? All right. Well, again, if you do the Boston Heart or the Cleveland Heart Lab, you'll be looking at four different markers. One is C-reactive protein, which any lab can do, inexpensive test. Another one is called fibrinogen, which is a active phase reactant. Acute phase reactant, which means if there's any infection or anything, it's going to light up. I kind of look at fibrinogen and CRP as very similar because they're non-specific. But the two that I really like are the LP-PLA2 and the MPO, the myeloperoxidase that I mentioned at the end of my little presentation here, because they really connote vascular inflammation, so it is more specific. but once I get these, if I have persistent elevation in CRP, I'm going to look beyond the norm. I'm going to see, do they have sleep apnea? Do they have oral, is their oral health being compromised? You got to remember that 60% of adult Americans have really poor oral health and some form of gingivitis. That is a great nidus for infection, inflammation, because bacteria go in those little deep pockets and they stay there, and you don't have to have bleeding and you don't have to have pain. So don't be, if you're my patient, don't be surprised if I send you to a periodontist, because I'm determined to get to the root of it. And when I really actually am suspicious of it, it always ends up being the real thing. And the periodontist ends up having to do what we call deep scaling and so forth. And there's quite a bit of inflammation. So it's a very important, that's an important test to do. And also the pulse test is another good thing to do, because it looks at biomarkers. So it looks at 9 different biomarkers, one of which is interleukin-16, things that you would never have heard of. But together, these biomarkers are a part of what we call a pulse score. And if the score is really positive and significant, it means that you have a lot of plaque going on that's active, and that is inflammation. So there's no lack of ways of food to determine your inflammation. I also look at the gut a lot, because the gut is, we're going to have a gut program soon. The gut is also a great source of inflammation. This new saying in functional medicine, actually it's not new at all, but if your gut is not healthy, you're not healthy. And there's definitely a gut-heart connection, and we'll be getting into that. And I also look at the gut. So if you come to me and you have inflammation, I'm going to do my best to try to figure it out. Okay, can berberine help with triglycerides? Berberine is a great supplement. I use it a lot. I use it actually, it can be used helpfully in metabolic syndrome and diabetes. A lot of people use metformin, which is a pharmaceutical, and which I happen to like very much. However, some people can't tolerate metformin because it does have some GI effects, and it can cause diarrhea and cramping. So berberine is a great second choice. And in fact, there have been studies that have likened the efficacy of berberine to that of metformin. So it's very good at decreasing your blood sugar. It also does have an effect with cholesterol, more cholesterol than triglycerides, because what it can do, it can act like one of those Pcsk9 inhibitors I mentioned, which actually works on the receptor side itself, which is the liver. So berberine is an interesting molecule. There's also another supplement that sounds like berberine. It's not. It's called bergamot, which is from a citrus plant in southern France and Italy. That also has, I've used it as a supplement. In fact, in one of my own supplements called CholesterWise. And what it does, it helps to decrease production of cholesterol in the liver, and also decrease absorption of cholesterol from the gut. So it works in the two places where we see cholesterol before it enters the bloodstream. And so those are the two supplements that I happen to like a lot. Okay, role of vitamin D in cardiac health. Okay, there's a big role for vitamin D in cardiac. You can see I don't like these glasses. Vitamin D is actually more than a vitamin. It's really like a hormone. I tell people that. And in fact, during this pandemic, of course, I came out with my own supplement for that called Inflammawise. But most important, I tell people, if you only have one supplement you can afford, make it vitamin D, because it is anti-inflammatory. So it is useful in heart disease. And they've done studies on the use of vitamin D, and there is definitely a correlation between therapeutic levels of vitamin D and less cardiac events. There's definitely been studies on that. And let's see what else. Are triglycerides on the standard cholesterol test? Yes, they are. Triglycerides are standard. But remember, if the triglycerides are really high, you won't get an LDL. Okay, let's see what else. What situations would you consider taking bergamot? Again, I use bergamot as another supplement. I will often pair it with red yeast rice supplement in a patient that I like to get the cholesterol down, but they're not so high risk that I have to go straight to a statin. So I use that combination because red yeast rice supplement works on the liver like a statin to decrease production whereas bergamot will work on both the gut and on the liver. So it's kind of a twofold thing. So I use the two together whenever I can. Okay, where do you see the future of heart health and treatment? Great question. Well, I like to think that what I do isn't so special. It ends up being special because not many people are doing it. I don't get it. I mean, most of my colleagues are treating heart disease. In fact, what we do in traditional medicine is disease management. Whereas what I do, I also like to think of promoting not so much lifespan, but health span. And that, of course, heart disease is still the #1 killer. We still have 655,000 deaths from heart disease a year and 850,000 heart attacks. So the future is, I still believe in lifestyle management. No one's going to convince me otherwise. So I do work on diet and exercise and stress management and sleep, and working on these risk factors. That's why I wanted to take a special program on this laboratory testing, because again, I go to it time and time and time again. And that's how when I see your risk, I look at these lab parameters. What can we do to decrease your risk? Not just to decrease your LDL, but to decrease your overall risk. So I'm looking at a much bigger picture. I think the future is bright. I wish, like traditional medicine, to take a larger role in this. They don't. And that's okay, because we are very good at disease management. But, I've seen too many people in my career have one stent, then another stent, then a bypass, then another bypass. Coronary disease, make no mistake about it, folks, coronary disease is a malignant disorder. It's as malignant as cancer because it tends to be progressive. And I follow with these coronary calcium scans that I do, and I'm friends with the Dr. Hdl who runs the center at Harvard UCLA. He says, "Oh, well, we expect like 15% to increase in coronary calcium every year." Really? So, okay. So what does that mean after 10 years? So it's expected that people's coronary calcium is going to increase. Well, not my patients. I mean, I have a few that first of all, I don't check it every year because it's radiation, that have really gone 9 yards. Okay. They've gone above and beyond the normal, and they've had very small, very, very light increase in the coronary calcium score. So lifestyle, and I really think it's promising. Okay. What situations? Oh, we talked about bergamot. I just want to make sure I got everything here. Vitamin D. One more thing, I haven't seen it here, but people always ask me about this. They ask me about vitamin K2. Okay, so vitamin K1, you've probably known about for years. That's involved with blood clotting. K2 is it is also vitamin K, but it works on calcium transport. So let's say you have a meal and there's calcium. Usually there's going to be some calcium in every meal that you eat. So what happens, it's got a very unique role. It will take calcium from your diet and transport it to where you want it to go, which is bones and teeth, as opposed to where you don't want it to go, which is the arteries and heart valves. So I use a lot of vitamin K2 along with my D3. So that's really important. What do I do okay, so that's the one good, you read my mind, Berkeley. How do you reduce or prevent coronary calcium? It's not that you can't take calcium. A lot of my patients, you might remember that years ago, everything was about calcium to prevent osteoporosis. Okay, well, we made a mistake because all we were doing was giving calcium, and we gave like 20 years ago, we would give like 1,500 milligrams to postmenopausal females. So I have my own product called BoneWise, and I use 750. I've reduced the amount by half, and I also add magnesium, and I add vitamin K2, and D3, and zinc, and boron, and manganese, because these are all involved with bone health. So the mistake we made is that we just gave calcium, and it was unopposed. There was no magnesium. So what happened, the calcium was going to the wrong place. So we can prevent a lot of this calcium transport issue, both with heart valves and with coronary arteries, by giving vitamin K2. I'm a big advocate of that. And I really think we can do a good job with it. Okay, let me just see if I've answered everything here. Vitamin D. Great question. I just want to make sure I haven't missed anything. Okay. Okay. Okay, here we go. Oh no, we did that. We did this. Okay. Okay. Okay, I'll give you one of my questions. The patient came in today. So this patient's been an athlete. He's been my patient for many years. He actually had an arrhythmia problem and had an ablation many years ago. It's done quite well. He's an athlete, a long-term athlete. He's a coach at a college. And he has been told to go on a statin because his HDL is always low. It's just genetically low. It's like 36, which is low. And his LDL is always like 125, 130. And he's been told to go on a statin. I'm saying, well, why? First of all, you just turned 60 or you're about to turn 60. You don't have any of the risk factors. You're very active, lean. I don't feel the need to work you up any further. I don't think you need to be on a statin. This is the kind of stuff you see all the time. I see women in my practice that have been placed on statins. See, women are like very vulnerable because they really care about doing the right thing. They're more in touch with their bodies than the average male. So they're going to do what they're told generally. And I see a lot of women being placed on statins that don't need to be on statins. That's why you really need, before anyone puts you on a statin, you really should have this kind of testing. I'm not the only one that does it. There are a lot of people that do advanced cardiac testing. I just couldn't practice medicine without it because, again, it's all about the risk, not about how low we go with your LDL. Okay, well, it's about 7:30, a little later than that. So if there's no more questions, we'll call it a night, okay? And we'll see you in 2 weeks for the next YouTube Live. I'm sure there'll be something exciting. I haven't figured out yet, but we will. And thank you all for tuning in. And get this testing done. Don't let anyone put the wool under your eyes. You have the power. As a medical advocate, you have the power to demand what you think is right. And, Boston Heart's easily accessible. You can't go any easier than Quest because Quest does this advanced testing as well. But my wish for all of you is to know as much as you can about your individual risk. And then it's easy to decide what therapy, if any, is needed, Okay, thank you guys. We'll see you in 2 weeks, okay? Thank you so much for joining in. Appreciate it.